Good morning, everyone, and welcome back to our second session with Dr. Johnson. I am Asna Khan, and I will be our MC throughout this whole conference. I wasn't able to join the first one due to technical difficulties, but I will be here now throughout the whole conference and will be your EMC. So we just had our first session with Margaret and Sister Fatima, and now we will have it with Dr. Johnson, furthering more about patient-centeredness and how it can be helpful for faith communities. This session will be now talking about how this can help George even more, and it will be about asset-based approach to train community health workers in faith communities. Dr. Rebecca Johnson, she will be presenting this session. She is a freelance researcher specializing in research, partnership, and facilitation, and her current work focuses on building the capacity of community-based stakeholders to engage with health research and researchers. So in this presentation, she will summarize the use of assets-based approach in PCORI-funded project EMPART that we were involved in. And she will also describe the faith-based community health training program where we placed 10 CHWs in mosque communities in a virtual environment due to the pandemic lockdown. And so she will explore the depth of the concept of research in community context and how we can amplify patient and caregiver voices through engagement. The spotlight is on you now, Dr. Johnson.
Okay, thank you very much, Asma. Can you hear me?
Yes, we can hear you.
Excellent, excellent. Right, okay, so I just wanted to sort of build a little bit on the excellent presentation that Margaret and Fatima did at the beginning, because I think they did a really good job of showing how we're basically, for George, his world is about his personal experience, but it's also about a collective experience. And in the world of research, and both community-based participatory research and also patient-centered research, the focus is therefore on this idea of well-being. So it's both, and the idea that it's both personal, and that changes over time as we live our lives, but also dependent to some extent on systems designed long before we were born in many cases, or which we may not understand because we have experienced other systems before the American one. So well-being really is a nice way of sort of summing up that combination of the social determinants of health, all of those factors that Fatima and Margaret so lovely brought out as being key influences, and the things that we experience on a daily basis, more than the healthcare system, obviously, but also the needs perhaps of individuals and citizens, patients like George, to be helped and guided to understand, to find access to the health system, but also perhaps to share their collective experience of accessing that health system as well. So, so well-being is an increasingly popular way really to describe all the aspects of our health, giving us a term that simply and easily encompasses physical, mental, emotional, financial, spiritual, but also the word access to care. So often, perhaps can't see this slide particularly clearly, but I think thinking about George in search of healthcare, it also may be the case that his experience of healthcare is not a positive one. So he may find that there are ethical or cultural challenges within the clinical health system when he accesses it for his diabetes or the issues that he has, the conditional issues that he has. He may find that those healthcare practices are culturally divergent from the Islamic tradition. He may find that the health system doesn't understand the global context, that the American health system is not really aware of the global system. So I was thinking, George comes from Armenia. He could be a Syrian Armenian, and he could have had experience of that health system before he came to the States. He could have been a Lebanese Armenian. So, and again, he would have an experience that a wealth of experience before he comes to America and of other healthcare systems. And those two things in of themselves can actually lead to adverse healthcare experiences, because not feeling that you are at the centre of them, that the patient, that you as a patient is being considered. And I think it often leads to health inequities, because people perhaps decide to opt out of the compliance is not there because of the experience of the healthcare system, as well as all of those social determinants of health that we visited at the beginning. So the idea of well-being is how do we move from our personal experience, which is really on a daily basis maintaining the 7 dimensions of wellness: physical, intellectual, emotional, social, spiritual, occupational, or environmental. So those are the 7 dimensions of wellness that we are all on a daily basis trying to keep going to stop ourselves from entering the healthcare system. And then there's the business of what happens when you do need the healthcare. And so putting yourself at the centre and thinking about how the community and how the can help identify the right pathway for the individual, such as George, through the really complex healthcare and clinical care system. Okay, so there is also the question of how community organisations and faith-based community organisation and faith-based settings, such as mosques, places like mosques where people go for their spiritual care as part of the wellness wheel, how can those places help support George's well-being? And is there a role for them in identifying the assets, or which we will go into, the resources which George needs or would feel most comfortable with to maintain his well-being, and also so that are the mosques a good place to go for knowledge about the healthcare that George needs? Is George is that something that, is there a role for a mosque in going beyond the usual wheel of helping members of the community maintain physical, spiritual, emotional well-being, and connect George to healthcare facets and assets? And this is a quote from the wonderful toolkit that has Dr. Padella and Fatima have worked on, and which we are disseminating today. The toolkit for mosque-based patient-centered outcomes research, and this is the quote about this is what the toolkit says about resources and the potential role that mosques can play in maximising their resources to support George, and by implication support the development of patient-centered research programs and interventions which are culturally sensitive and specific. So what Dr. Padella and the team say in the guide is, given the influx of economic migrants, immigrants and refugees into Muslim communities in the US, there's a constant need for mosques to find better and creative ways to maximise their resources to support the growing community. And as a result, a basic level of interdependency will exist between the organisers of the mosque programmes and the community members. And in the guide, Dr. Padella and the team identify that two areas where mosques already support their communities. So mosques support communities at many different levels, from meeting the basic religious needs of individuals, which is the spiritual dimension of the wellness wheel, to providing social and educational services. And one thing I have learned so much from working with the Worry-Free team and all the members, all the people who joined us on this journey of working out, the extent to which we could do patient-centered research engagement, is that mosques do a lot in these areas, and food banks, education are two areas in particular that we had. There were a lot of assets where we could share, we could talk to each other about what mosques did to ensure that people could have access to halal food, that they had access and understanding to Islamic teaching about Islamic values and practices when it came to engaging with the healthcare system. Now, what the guide also says is that these relationships can be leveraged to engage mosque communities for a patient-centered outcomes research study. And I think that is potentially true. But what I wanted to do today is to share to share with you some of the ways in which that manifests itself in practice, and so that you can make your own decisions to see whether the engagement with the patient-centered outcomes research agenda, methodologies, as Fatima so well outlined, is for you and your community. So a resource, just focusing in, what is a resource? So a resource is a stock or a supply of money, materials, staff, and other assets that can be drawn on by a person, George, or an organisation, a mosque, or Worry-Free, in order to function effectively. So resources can also be natural features or phenomena that enhance the quality of human life. And I think one of the things I've come to realise is that there is a fundamental disconnect between research that focuses on social determinants of health and research that focuses on clinical practice, because or focuses on sort of extending life or extending or improving the quality of life through clinical practice and interventions, because of their goals. And in the case of the first, the social determinants of health, research is looking to improve the quality of life. In the case of the second, the measures that are collected by clinics, hospitals, are really about longevity and how long one can, so the mortality rates are driving a lot of the research, in the sense that people want cures for particular conditions. And those two things, I think, as Fatima and Margaret said so well at the beginning, they need to come together, because I think often they seem to be competing with each other. So in terms of assets, so basically the question to ask is, if you're an organisation, the question to ask is, what assets do you have? If you're an association, the question to ask is, what assets do you have? The question of an individual, what assets do I have? And there are potential and there are actual. And what I want to do today is to introduce you to a tool called asset mapping, which helps you to identify the assets which could be valuable to you in terms of building knowledge and understanding of health care and the healthcare support and system. So one thing I really want to stress as well is, one thing that, as Margaret said, faith-based communities are very good places to work through potential engagement with researchers on interventions that might help community members, because they are so well placed. They have so much rich social capital. And as you can see here, the religious group is the religious groups. So you've got the individual client, individual consumer of health, person, citizen. You've got the religious groups, and you can see how many circles the religious groups actually overlap with. So there's the acquaintances, employees, so there's the community, there's the networks, friends, colleagues, residents, there's the buddies, treatments, teammates, buddies, neighbours. And the one, even here, you can see is that religious groups connect with the CDCs and employees and schools, so that there is that it's the larger community that sometimes religious groups struggle to work out what type of relationship to have, because often these are led or manned or personed by people that are unknown to the groups. Okay, so in order to help you think about the personal experiences, I wanted to share with you a common measure for adult well-being, and this is something that you can use with just as a sort of a starting point, a sort of a way to begin to talk about well-being, remembering that well-being is all of those that wheel, remembering the wheel, the wellness wheel. And what can be quite useful in groups, with community groups, is in order to understand either your community's well-being or the individual, is to actually use this tool with members. So, for example, in a Baptist context, a faith-based community Baptist context, I would use this tool with the members of the church who are training to be research ministry ambassadors. And I would ask them to imagine a ladder with steps numbered from 0 at the bottom to 10 at the top, where the top of the ladder represents the best possible life for you and the bottom of the ladder represents the worst possible life for you. And I would ask them to indicate where on the ladder you feel you personally stand right now. And it was so good to hear Fatima talking about coming back in 2 years' time to think about where we've gone forwards, because that's also incredibly important as well. You know, where on the steps you think you're going to be in 5 years from now, and then perhaps coming back and sort of revisiting that and seeing how far we've got along the line. So in terms of a starting point, my experience is that starting with the words like patient-centered outcomes, or even, you know, clinical conditions like hypertension, are not good places to start a conversation about research with communities. Communities have their own words or their own sort of notions, and perhaps beginning to understand the social determinants of health and the way that they are operating from a personal and a community perspective is very helpful. And actually just having a general conversation about how you would characterize your community's well-being, or who's thriving and who's not thriving, is a great start. So I just wanted to share that tool, because part of my role here is to sort of help you to sort of identify some tools to get going, and to help make that decision about whether or not engaging with the healthcare system is right, and identifying the assets that everybody will help you to do that is right for you. Okay, so I'm not sure we have a poll, but one thing I would just like to have a little bit of a pause, and maybe you could put this in the so we could. I would like to ask everybody, which of the following is a personal known? So think of yourself as a person, individual. You could be George, you could be Fatima, you could be Margaret, you could be me. So which is the following do you personally know? Do you know the geographic location of trusted health providers? Do you know the history of Muslim American populations in Chicago and the suburbs, or the history of immigrant populations, how the healthcare system works? So let's try the first 4. Which of those is personally known to you? If you could put in the chat A, B, C, or D. I can't actually, Asna, I can't see, I can only see my slides. So could you let me know what's taking place? Oh. Asna, are you on mute? I try to reduce my screen. It's not working. Okay, I can't see what's happening, so I'll just talk through this this idea. So what I'm suggesting here is that it's a good thing to do a knowledge check, to just have a pause, and to ask yourself, what do I know? Just to say, as a researcher, I believe passionately that knowledge is power. Which of course may not be an assumption that not everybody may be starting from that assumption, but as a researcher, that's what I truly believe. And I also believe in the power of methods. So I think the first question is often to ask, what do we know individually? What does the organization that we, such as a mosque community organization, know? And what in the case of Islam and Muslim Americans, perhaps also which of the following is an ethnic community known? Because one thing I have really learned and has come home to me is, first of all, that Islam is the third biggest religion practiced in the States. And secondly, that actually there is no one dominant ethnic minority group. And that's beautiful, because actually that means as a group, there's a lot of diversity there. But obviously that's harder for almost community organisations possibly to support. So these are questions which I think I would encourage you to think about and perhaps answer in your own time. Okay, so moving on, now we've got how do local community organisations make resources productive? So how are we going to move to that outer wheel, as it were? And this is where I think often community organisations begin to feel a little bit uncomfortable, moving into areas where they feel they don't necessarily know, and they're going to have to go through outside agencies. Sometimes with a little bit of help, and sometimes you just have to dive in and trust the outside agency. And sometimes we're forced to trust the outside agency, as in the case of government and federally sort of driven policies. So how do we sort of build on the assets that we already have in supporting the wellness wheel and the well-being of folks like George? How do we then extend it a little bit so that we increase our knowledge and understanding of the healthcare system, and also perhaps from the grassroots up, and engage with people that we don't know as well as those that we do? So today I want to introduce you to the ABCD tool, which actually is a brilliant title. It stands for Asset-Based Community Development, but it's also, the alphabet, A, B, C, D. And this is beautiful approach, which was produced by Professor John Knight, who is now, he used to be at Northwestern, but is now at DePaul. And there is actually the Asset-Based Community Development Institute at DePaul, which I'd really encourage you to go and have a look at, because they do also have specific guidance for faith-based communities and workshops which help faith-based community leaders to develop asset-based community development processes. Now, this is actually rooted in CBPR, to go back to Fatima and Margaret's point. So this asset-based community development was was a key pillar of CBPR. So what we're now looking at is how we can extend it, I think, and so that you can use and we can identify assets which help communities engage with clinical sort of settings, and also clinical research settings. So the way that the asset approach works is that it identifies 4 essential elements and 6 asset domains, and then it thinks about methods and functions in terms of how you're going to get those assets identified. And then it talks about, most importantly, it talks about your gifts or our superpowers, because the biggest assets in any community are the community members. And then I want to share with you the worry-free asset map that Fatima and the team have started to put together as part of the EMPART programme. And I think I'd really like a discussion at the end. So as you're thinking, as I'm talking, please think about, is this for us as a individual mosque or as a group of mosques, or is this something we would like worry-free to continue, sustain? Would we like to be involved in that? Is it something that we can see could be useful to us? Because okay, so let's go forward. So the 4 approaches are the 4 elements in the asset-based approach. The first point is that the whole goal of an asset-based community development process is to enhance the collective visioning and production of healthy communities through a process that combines resources, methods, functions, and then also demonstrates the value. So the first question is, what resources do patients, citizens use to foster well-being? And we're adding healthcare to that as well, including healthcare. The answer is often local resources, and what that means is assets or resources which are used to enhance well-being within your neighbourhood. They could be associational, cultural, environment, organisational resources. And then the method is having addressed the question of what individuals access, having found out what helps them, how they navigate their well-being, and we're adding the healthcare system. The next question would be, how do communities go about making that, leveraging that, in the words of the EMPART? How do we take that forward? And the value of that is that it enables groups of mosques or groups of organisations to advocate for the development of other assets, or identify gaps, asset gaps. And so, having used the methods to discover, connect, and productively mobilise the resources, the question then becomes, what functions are citizens and leaders are able to collectively form that create greater community well-being? And this is where community health workers, I think, you as community health workers are so valuable, because you could potentially have an essential function in connecting George to individual like George to the healthcare system, to the research opportunities and interventions, as Fatima mentioned, which are specifically being developed for immigrant communities. And equally, George might have a function advocating for himself. And as such, PCORI encourages people to join them and become ambassadors. And one of the great things of everybody who went through the EMPART training program was that they all became PCORI ambassadors. So there's the individual can have a role, the professional can have a role, and this is all about connecting the dots and leveraging up. So there are 6 asset domains. And what that means is that they're all contributions from you and your social networks, everything you and your families know. They're all contributions, or the links and knowledge things provided at a local level in neighbourhoods and by schools, food banks and mosques. There's also information that you can share, and often that is part of the contributions from you, but it could actually be from organisations that you don't actually have personal connections with. And then there are stories which often prompt further discussion, and they could be about the history of the community, or they could be stories from the home countries, or they could be individual stories. And then there are also the associations like Worry Free, who are providing information and services. So I wanted to share some examples. So we've talked a little bit about George, but I wanted to give you some other examples. So here we have Aziza's story. Now, Aziza has not had an easy time merging her faith with her disability. After losing her father and starting to use a wheelchair, Aziza and her family turned to their local mosque for support, but accessing the mosque proved difficult. And this is actually a news story which was published on the Northwestern Medill site, and it was talking about the intersect between disability and Muslim identity. And so what the trainees, community health workers who took part in the EMPART project did, is that we looked at what the Chicago, what we could find out really, but we wanted it to be culturally appropriate. And so we went to the Chicago Area Health Atlas, and this is an atlas which includes health and wellbeing data, and it's searchable by community and zip code. And it also actually includes all the mosques. So there are, well, I'm not sure whether it's all the mosques, but it includes, it maps out local institutions and local places. So I don't know which particular mosque Aziza was local to Aziza, but what's interesting is that these are other mosques maybe that might have information which would be helpful to determining how to improve accessibility to the local. It depends how small it is, how much resources there are. All of those things are important to consider. And the information you can share, what we did is we shared information that we all knew, that as part of, we had a meeting and we shared information that we had accessed as, in my case, a researcher, in Fatima and the team's case as a provider of services, and as some of the members of the team's trainees one trainee had come from Lebanon, and she had a story of her story of working with Down syndrome's children in the Lebanon. So there is, as assets, people as assets are just amazing. People have so many assets, and the one thing I could share is the Access Living information, because I have a relationship with Access Living, and there are many. It's a very good website. And it was through, and then Fatima and Worry Free could share the information about the I'm not sure I'm going to say this wrong, the MUHSEN sort of initiative, which is thank you, thank you, Wilson, which is an amazing initiative, and I wanted to give you the background, a little bit of background to that, because this was developed by Dr. Omar Suleiman, and he was the president of the Yaqeen Institute for Islamic Research and a professor of Islamic Studies at Southern Methodist University. And he founded the Institute for the Yaqeen Institute as a think tank on focusing on installing conviction based on Islamic texts and producing contributions. And Muslim stands for Muslim Understanding and Helping Special Education Needs, and it's a non-profit umbrella organisation serving the community to establish a more inclusive, special, friendly environment for our brothers and sisters of all disabilities. So here you can see how we've got the, we have a specific cultural resource. We have a personal story from a global perspective, and we also have information, local information from a body which does not, when you go on the website, does not show a cultural understanding of Islam. So it's how this is all the different assets that are available to us, but with the different types of characteristics. Okay, so then if we take Umar's story. Now, Umar, this is actually Local Voices Network in hosts this story. And Umar was talking to a reporter. This is the Wisconsin News. Yeah, I was trying to think back to when I was in middle school. I would have benefited greatly from a counsellor, mental health specialist, something like that. Although I wouldn't say I was experiencing trauma per se, but I was struggling with what many people in that lifetime frame experienced, just like figuring out who the heck I am, especially balancing culture with religion and identity, and my Americanness with my Indian, Pakistani background and all of that. It's definitely a big challenge. So again, here's a story which is out there. And in this case, what's interesting is that Umar is in Madison, Wisconsin. And so, but my understanding of the mosque networks and please do correct me if I'm wrong in this, is that there are many connections. What's unique, partly unique about it's something unique about faith-based communities, I think, because it's similar with the Baptists, is that the Baptist churches I work with on the South Side, is that it's not just the South Side, they're part of the Midwest Baptist network. So it would be possible, I was thinking it would be possible for Umar's story to reach or to be heard in a Illinois context, even though he's in Wisconsin. And I wanted to highlight this story for two reasons, because if you look at here, this is the Robert Wood Johnson. So going back to Fatima's point at the beginning, Robert Wood Johnson is a good source for community organisations looking at trying to identify assets. Well, they're trying to identify the social and determinants of health issues, but they're also looking to identify solutions and interventions, evidence-based solutions and interventions. But what's interesting about this map is that it's trying to show you the measures of well-being, actually health outcomes. It's measuring health outcomes, and that means, as I was saying before, a healthy outcome is determined to be good if there is longevity, if life expectancy is long. The blue map is about health factors, so that includes a little bit more of the social determinants of health. Now, of course, if you look at Madison, it has excellent ratings. And so the reason I wanted to share this is that this goes back to the point I think that Margaret and Fatima were making at the beginning, is it's very easy for Muslim or immigrants to America or Muslims who are American citizens and have been here for a long time. It's very easy for their voices and their stories to be sort of swept away by the data. And yet it's quite clear that Umar could have done. He probably was, according to the data, everything is, rosy, but he could have done with some counselling. And so what the Robert Wood Johnson have been doing is they've been trying to find out what works for health. So they're saying evidence matters. What works for health helps you find policies and programs that are a good fit for your community's priorities. So it's very much, science for the community, but it's still got all that language in there, which is a little bit of a barrier. But again, as community health workers, I think the more I talk to community health workers, I think they're beginning to see their role as translators. That they can, and this is a great site to go to. So if you continue, for example, and what's happened with the Robert Wood Johnson site is in the past it just used to say, here are the results, the health outcomes. Madison County is high, it's Dade, isn't it, I think, but another county has a low rating. But what they've started to do is they've started to identify strategies and interventions, evidence-based strategies and interventions which work. And so here's an example of school-based trauma counselling, which obviously Umar could have benefited from. And this, interestingly, so they've started doing this evidence rating. And so as a community organisation, you can go to the site and you can type in a condition or a social determinant of health, and then find out an intervention that will help. You can find out where it has been done. In this case, what's great about this is this was a Midwestern initiative. So it included Illinois, Indiana, and Wisconsin, and there were others as well. So you can actually find out. And why that is good is because it enables you to then track down the intervention, the researcher who did it, and if this is an issue which resonates in your mosque community or with your organisation, you can follow up. And this is an asset. This is an example of a research asset which you can follow up on. Okay, so let's take George. Let's go back to George. So I've embellished George a little bit. So apologies to Fatima and Margaret. So I've made him a Syrian Armenian, and he's arrived in Chicago. And his preferred language is Arabic, which goes back to Margaret's point right at the beginning, is that speaking to people in languages that they prefer is crucial here, particularly if he's trying to engage with a new system. The other thing I did some digging, and I found that in order to come to the States, George would have been required to take a pre-departure medical screening. So it may be that he didn't know he had diabetes until he did that screening. And so he's got that shock of being diagnosed with, he's on an everyday basis, he was managing his well-being, and then he gets a diagnosis, and that may be, that will colour his experience as well of America and the healthcare system. And also, anyone coming from Syria there's a requirement that you get treated for intestinal parasites. I came across this when I applied to come to the States because I got tested for HIV and AIDS. And so there are things that people get tested for, and it doesn't necessarily make you feel warm and fuzzy about the healthcare system. Okay, so with George, I then wanted to take the opportunity to introduce you to the Worry-Free Community Assets Maps, because if George is Armenian Syrian, and he's arrived, he wants to speak Arabic, and of course there are many Christian Armenians as well. In fact, the Orthodox Church the Armenian Orthodox Church is quite strong. So locally, the community he might find himself living in, the Armenian community he might find himself living in, may be heavily Orthodox, and he's Muslim, and he wants a sort of help to navigate that part of his identity. He's also Syrian, so he wants help navigating that part of his identity. And so what Fatima and the Worry-Free crew, what we did is we started thinking about what would a community asset map look like, which was which brought together all of the assets that we knew about, and also were either we knew about, mosques knew about, and other things. We had to decide about those other things that aren't culturally informed, and what would that look like? So this is what we tried to have a go at doing. Hyperlocal asset mapping is something that's happening a lot now. I mean, some of you may have come across NowPow. And the idea is that you map out every place. It could be a restaurant, it could be restaurants, businesses, healthcare systems, housing, and you help people to navigate that system. And that is what that was the idea of the asset map, the worry-free asset map. The reason why this is actually quite exciting is because what it enables you to do is to deliver whole person care, or it enables you to address food insecurity, because it enables you to connect folks like George with the assets that the trusted assets that because they've been, they're trusted because they've been recommended by people that you know or you like, or if you don't know anybody, or are culturally appropriate, and if you don't know anybody, somebody else has vouched for that asset. So, community functions. So there are 7 community in the ABCD, going back to the asset mapping tool. There are 7 functions that the ABCD posits community organizations can do. They can enable health, they can ensure security, they can help with stewarding the ecology, shaping local economies, contributing to local food production, raising children, and co-creating care. So these are the 2 that Fatima and Margaret so well laid the groundwork for you: enabling health and co-creating care, because these are leverage. You already do the security, the economies, the local food production, the raising our children. Those are things which are part of the well-being of a spiritual or religious organization or support as part of is often part of that. But the co-creating care and the enabling health are these new ones that we are suggesting it could be useful for mosque groups and communities to engage with. And the key thing, I think, is it starts with the grassroots. It starts with you, it starts with George, it starts with Fatima, it starts with Margaret as a student of community health, it starts with mosque leaders. And then the role of professionals is it comes in after the community functions have been identified, perhaps not performed, but identified. And so what I do want to say as well is that the heart of this movement is the idea of gifts. This is our superpower. So it's the gifts of the people in our neighbourhoods are boundless. Our movement calls forth those gifts so they can be reciprocated. The power of association. When we get together, we join together, and they become amplified, magnified, productive, and celebrated. And like as in the case with George, we welcome strangers because we value their gifts and need to share our own, and our doors are open. Okay, so we have gifts of the head, we have gifts of the hand, we have gifts of the heart, and I wanted to, let me see, yeah. So where next, basically? So what does success look like? Well, what we want to do is we want to have effective asset mapping for community health and well-being. We want to maximise the gift exchange, maximise and deepen the social life, maximise the numbers of participating and co-producing residents, and collect and share the evidence of impact. So in order to make sure that the grassroots and the mainstream are not in conflict, but are actually are a stream, a constant stream, so that the community histories, lived experiences, stories merge seamlessly into all those other assets that we don't have personal links to, the government data, academic reports, and often newspapers as well. Okay, so I think what I want to do is just stop there, and ask you, I'll come back to these things, but I want to stop there and ask if there are any questions at this point. Okay, so let me see what's this in the chat. So, okay.
So the chat says, Yaqeen is one of the best organization happened to Muslim community post 9/11 or 2001 or 9/11 basically events, and that is the Omar Suleiman's organization, and he is in fact with his contributions to the community about the Islamic concepts and about the religious concepts has really he has blended both community, faith, and health and social services together. He does a great job. Yeah, I agree with that, Sundus, definitely.
Okay. So obviously we've shared a lot of information at this point. So, and I'm not quite sure how many representatives there are on the call from the different groups that we're sort of talking about. But would anyone like to share whether or not they think the asset mapping idea is something that worry-free, it's a good investment to go forwards, and with the idea that these are assets which are vetted and selected to improve well-being and health and access to care.
No, I can tell you about that, Dr. Rebecca. Sure.
Let's see. Okay, there's the biggest benefit is the resilience in it. Oh, okay, that's really nice. I love the word resilience. Yes, I absolutely agree with that. And there is a lot of discussion at the moment about resilient communities. Yes. And the idea of a resilient community is that it knows its own vital conditions. That's the key. And so, I mean, the weakness with our presentation so far is it's quite generic, obviously. So knowing the vital conditions in your own community, whether it be faith-based or social or neighborhood, is a route to resilience. And if that's an outcome you want and you desire, I would strongly recommend that you do asset mapping and that there's an agreement on how to take that forward so that everybody that you serve benefits.
I agree.
Okay. Yes, yes, I agree with all of that. Saunders, very good. Yeah, so yes, so it makes it a framework. I'm not quite sure what you mean by rather than standardizing it. I'm thinking you're suggesting that it can be tailored for community, which is good, which gives communities autonomy. Yes, absolutely. And empowers communities to take on more accountability towards asset identification and recruitment. Absolutely, yes. That's what I believe passionately. That that's what it does. Yes, it enables us, and we that's what we discussed as the group. We felt it was a way of building and expanding on existing community strengths, facilitating community involvement based on knowledge and understanding. Because the whole business of language is so difficult in terms of, there's all these different worlds with different language. It really is like translating sort of different, it's like having Arabic, English, it's all of these different, it's a constant sort of translation issue with the jargon. And so, yes, I agree with that.
I just want to add that, Dr. Becca, just what you said right now. Sorry about, we're having problem with translating this technology into our the ways we want to get it done. But what you just said is that as we are developing in sciences and technologies and having advancements in different areas of our lives and different domains of our lives, we're developing new concepts. Each concept is lending its way into a different language. And what we are finding out ourselves is, we may not understand that language, and therefore we need to translate it. So I just want to bring home the point that the process of translation is a very powerful process. It's a deep-rooted process, and it actually transcends different layers of our understanding. So we need to possibly simply go beyond the definition of NIH's, that Translational Sciences Institute definition of just translating research into the behavior modifications. It actually is very deeply rooted in all sectors of our lives today, with all different types of advancements that we are having. So yes, indeed, that's going to be possibly the key, because we're all learning different languages.
Yes.
And translating it for each other.
Yes, and that's very interesting, actually. So Sondas has asked as well, how do you see the current barriers in faith-based community resolved? And also, how do you think a secular sect, as healthcare system is, would envisage collaboration with faith-based communities? Those are both excellent questions. So perhaps with the first one, how do you see the current barriers? So well, I'll tell you what I think some of the barriers are, but I would welcome others to share what they perceive the barriers to be. I mean, I think one that's come out very strongly is actually the point that Sondas makes in the second bit, which is that the biggest barrier is the healthcare system is secular. That can be a huge barrier. Or is it? You see, that's the thing. I actually think that Western medicine is quite ideologically driven in terms of its values. That there's a Western bent to, and by that I mean European, really, in the sense that ethics and decision making and consent are all rooted in English law. And what's interesting about, and so I came across this with Confucian, looking at Confucian law, and so in Chinese medical decision making, the familial is much more to the fore. It's not the individual. So negotiate that in itself, I think, is a big thing. The way that the family is not included in decision making is a big thing for faith-based. Is a big barrier, because in my experience of the Baptist, family is crucial. Family is what does the caring. Family is where you talk to your family and find out whether or not you have a history of high blood pressure. You do, you get to the point where you may have a history where there's dementia and you need to plan for it. And so the whole idea of collective responsibility is absent from the. There are very few areas where there are family conferences. There is in palliative care, interestingly enough, because that's where they sort of coming across very difficult decisions, usually to do with end of life. So that is the values is a big issue, I think, and the way in which the healthcare system seems to be trying to deal with that is by having hospital-based chaplains who are not, who are all faiths. They sort of, I can't remember the right word for that, but you're not allowed to be, an imam, or you're trained. You have chaplaincy training to deal with Catholic, Protestant, Muslim, Hindu. You're multi-faith in your now. So the healthcare system would envisage collaboration partly through those personnel because they are hospital based. But what I think we would like to see more of is more engagement, more understanding of the other way around. So it's grassroots, worry-free community health workers being the bridge, that clinical. So it's the community. I can see a really great role for community health workers in terms of the negotiation and the leveraging and the relationship building. But there's a lot of education needed. And I think, I do actually think that's something that the Islamic community could help with. So I would encourage everybody to have a look on the CDC, because when I was thinking about George as a Syrian Armenian, I went to the CDC website and there are some tips for clinicians. You know, if George comes into your clinic, be aware that Syrians are very highly educated. Before the war, Syria had a very good education system. It had a healthcare system that was quite Western in the way that it operated. So George would probably be quite familiar with some of the things that he was experiencing. But it also said George is probably likely not to be compliant with his meds. And so there's a whole series of things. And I'm thinking, yes. So that is obviously, yes, it's important. But this whole business of treating a Syrian Armenian as a sort of, clearly identifiable identity with these issues and these problems. So I do think that mosques and Islam could have a really great role in educating the system about where it's going to come a cropper and what the barriers are.
Yeah, that's absolutely. I agree with Sundus that your transparency and genuine answers are so refreshing and heartwarming. Absolutely. And these are some of the candid discussions we need to have. And in fact, the last point that you made, Dr. Johnson, it's beautiful that this is the point that Initiative of Islam and Medicine is making, the Islamic bioethics. And in fact, the bioethics is very cultural and deeply rooted in the belief systems. So all ethics is, in fact, so we've not really, and being secular, we take that out, but do we take ourselves out? Do we take our biases out? No. And that is part of the reason why, going back to PCORI method, and all of these things do come together so well on the PCORI platform that the Bayesian trials, the methodology talks about. It actually has those implicit biases rooted in how to handle them. And it as part of as part of coming up with a new treatment option or an engagement project. So I think we all have to work together, and as you mentioned, step by step, going back from grassroots all the way to policy and understanding these techniques and measures that we are taking in the middle to evaluate and to understand each other and keep moving. Yeah, it's very refreshing, and I'm so one of the things I got to apologize for, because this platform doesn't seem to actively engages people in the dialogue. So that's what I'm really missing out on this, and I'm unable to put my comments in the chat. So that's how I recognize. I'm so sorry. I have a chat option here. Yeah. So these technical hiccups, it's just that. It should have been an in-person and really a heartwarming environment. Unfortunately, we have to deal with it with this virtual. But I'm hopeful that once we cross this technology barrier, we would be able to be inclusive of many more people that are in different places at the same time. Yeah. And so it definitely has some value in it for inclusivity. Yeah. With this, do you think you want to conclude the session? And
yeah, sure. I can share. I can share another example actually, which is a recent one. Is that so? I think as Asma said at the beginning, I work with Mosque-PCOR, and they have engaged with a clinical study. So there's the whole business of okay, we all get involved and we understand the system, and then what happens when we actually engage when I say we, in this case, it's a community organisation, is one of the PIs on a project, and this is a project to reduce hypertension in African Americans. So, but what's interesting is that the driver is the clinical model. So basically, we've been discussing how it's a Kaiser bundle. It's a bundle which is basically, the idea is that this is evidence-based, it's proven, and it's a registry. The idea is a registry. You then so you have to register people. You then give them cuffs to monitor their blood pressure. You diagnose, you work them, you give them education, you talk to them about high blood pressure, you then give them cuffs, you then sort of monitor it, and and it's clear to me that from the clinician's point of view, this is very obvious, that you go through these steps. But what the community group has saying so well is that before you even get to the point of talking about hypertension, for example, everyone switch off. Absolutely switch off. So a better place to start, shared by one of the members of the group, Dr. Kandula, who works with South Asian Hindu and Muslim groups. She said, if you start by having a discussion about stress, and then as a group, and that's why I wanted to share that tool earlier on about, start with a general discussion, and then work out whether this particular intervention of monitoring your blood pressure is going to be an intervention which helps somebody. So you work together to working out what's useful. And I'm finding this very, very interesting, because in some ways the community comes first. The community sort of talking about the social determinants of health that you so beautifully highlighted, Fatima, is more important to the community than hypertension. It really, we live with our conditions on a daily basis. That's not the main thing. It's probably whether or not you're going to get to work, whether you can feed your children. These are the main things. So it's persuading clinicians that they need to do that step before you get to the intervention is difficult.
Yeah, absolutely.
Yeah.
Absolutely.
But yes, I can just I
just wanted to ask you one thing, because we have all of these different sectors within community, and the forest and the seven steps that you talked about, not seven different categories that you talked about. There seems to be relatively siloed in when they are working in their own environment. What is your approach, or what are your suggestions for these people to kind of work together? What would be the collaborative incentives, or some ways that they should be working together?
Yes. So, yeah, I mean, to be honest, for the researchers, they're not going to move the needle on behavioural change unless they address these things. I mean, I used to have a graph in my office which was about money invested in, I think it was physical activity. Let's take physical activity. All these interventions on improving people's physical activity, or their eating habits. And they're just trying to do these interventions, but they weren't working because they weren't taking into consideration these other things. So all this money goes in, and there's flat lines. There's no impact, and that's not. From a researcher point of view, there's a lot of benefits, and I think they are waking up to that. And I think PCORI, from a community point of view, I'm not sure. You see, I think there's a lot. I think the value of the community to the researcher is more than the researcher's value to the community at the moment. And we need to make that a much more equal relationship. And the way in which I think that can be done is to help community health workers be those translators, or have people in the community who are those translators, who are properly funded, sustained, have access to the university resources. They look both ways. It's like a Janus. They are in the middle of that grassroots mainstream.
You've just brought a really good point. So which means that the researchers' values, the community doesn't see that value in researcher. And I think that's probably they're not seeing because they're not connecting with them. And that's probably not that is the, and they are not connecting because the researchers are not connected with those 7 different categories.
Yes.
So if we connect these researchers to those assets that you have just talked about, I think that's where the community is going to recognize the value of the research. And so that disconnect. So perhaps from one of the take-home messages for us as a community-based organization for the next 2 years that we are embarking on the next phase would be to focus on building those relationships so that the community understands the value of that research then.
Yes, and when you do have relationships, I mean, I would think, I know, to assess my usefulness, as it were, to passes for PCOR, I would say that's my access to knowledge about resources. That once I've heard the issues, I can then go away and do a literature research, or I can go and I can target it. And so if I'm being, so the community can use the researchers to do to say, well, here's what the research tells us about X, Y, and Z. Which one of these is useful to you? And I think so the best bit of a work plan, of a research work plan for the community, is often the contents at the beginning, the context at the beginning, where it says, we're doing this because, it fits into this bigger picture.
That's interesting. So, okay. Oh, this is great. I mean, you've just opened my eyes to one of the main strategic initiatives that a worry-free community can actually take. In fact, we have been recently approached, and we do get, because as a community-based organizations, we get bombarded with all kinds of stimuli.
That's right. And that's hard. That's very, very hard. That's right.
And one of the things for the COVID hesitancy, for example, they are trying to, the government and the CDC resources and the research bodies of knowledge, they're trying to figure out why is there a hesitancy. So they are going in and actually asking different community groups as to what is it that it matters to you, what are your preferences and choices, and why they are such. So connecting to the different, so we recently have joined hands with DuPage Health Coalition. They are also one of our community-based partners. They are also debuted in our acknowledgements. Thank you, DuPage Health Coalition. So they are investing in the time and the resources where we're having focus groups in different communities for a smaller, for example, such as MENA group with the Middle Eastern and the Nigerian African communities, and the South Asian communities, where we're talking to these groups as what is it that matters to them? What are some of the basics or the reasons for their vaccine hesitancy, or even vaccine preference, because it goes both ways. If the vaccine preference is missing in the other community, why would there be? So we have an opportunity coming up. In fact, because of DuPage Health Coalition, we have put these focus groups together in I believe at the end of September and in October, where we would be having this dialogue within the different community groups. So facilitating that as a community-based organization is our role. We are connectors. We're one of those asset-based, connectors. That's it.
No, you are, Fatima. But I would also strongly, if you can bring in legacy or history, that is very. I think so. It's not just all about the now, because I think, for example, I was very shocked when I heard that people were taking that sort of drug for animals. There's some people have been drinking this. They won't take the vaccine. They're anti-vaxxers, but they've been taking this stuff which was developed to treat animals. And I thought, well, why? I can understand why you don't want to take anything, but why would you take something which was developed for animals? When you don't know it's been vetted or and it really worried me, that because to me that showed just how deep the distrust of the health system goes. And I think it's about lack of transparency. So the reason why they were prepared to take something for animals is because they'd seen animals take it. And they'd seen that nobody died from it, you know, and I didn't think that worried me a lot, that because I'm thinking we are not transparent enough as a public healthcare community. We are not transparent enough. And we cannot, I don't think we can emphasize that, the importance of transparency from that point of view. Yeah.
Interesting. Yeah.
But I think it's a great question, and it's a question we did ask actually. We've, as you know, I think you might have even been there for Selena and Sabrina's presentation, which was looking at COVID, why there was lack of COVID, why was the reluctance to take vaccine in those 2 zip codes areas on the south side. And I thought that, again, that was very interesting because they were talking about people in their own families who weren't going. So somebody had taken the vaccine and somebody hadn't. And so, yeah, definitely explore that, because people sort of assume it's about misinformation, but it's almost like tracing that backwards, isn't it? And finding out exactly how that has led to that decision.
Yeah, we're having an informal discussion, and I got to share this with, and I miss out on the audience discussion, which is really, I wanted to see that much more. Anyways, one of the answers we received from, because we have the free clinic, by the way, we would be having the free clinic session starting at 2:30 today. And so when we see patients in the free clinic environment, we usually ask them, have they taken the vaccine, or they haven't taken the vaccine, why not? And what are some of the reasons? And so one of the answers that I have heard a couple times was, because it's not a mandate. The government doesn't think it's safe. I'm like, whoa.
Right, that's interesting. Yeah.
So basically it's the trust that if the government thought it's trustworthy, then it's going to mandate it. And unfortunately, we are living in that era of private and for-profit, not-for-profit medicines, where it is a capitalistic enterprise, and so the government is not going to mandate. This is a philosophy. This is a government philosophy or a political philosophy or ideology that people outside this country are not used to. They are used to being handed down and a solution saying that, oh, here's your solution, and why don't just take it? This is what everyone does, and this is what you're supposed to do because you live in such and such country. Right. And so that's how they're much more willing to take orders, because that's where the authority and the liability both reside, rather than, oh, this is your responsibility. And so I don't have the liability. I can only make suggestions. The liability is carried by the third parties here.
And that might go back to, certainly with immigration, that might go back to the whole process that you're so
there is another dimension to this whole thought process. That when you have this kind of an open and the secular sect as healthcare, so this is called, it would be, where does the liability lies? And who is responsible for me to make that decision? Am I responsible? If I'm responsible for making that decision, then do I have enough information about it? And that's where the informed consent or the informed decision making comes in. So, I mean, all of these dynamics is really toggles back and forth and brings back the point.
Yes, it does. Yeah. So I will reshare, and just I didn't have that many slides left, really. I was let's see, so share. I think it was just to leave us with some thinking points, which is basically, if we're going to carry on with the worry-free, if we're going to carry on with the worry-free asset mapping, there are what we can identify from what we've already done is that there are already some emerging desirable characteristics. I think you'd agree with that, Fatima, is that as we had that discussion, it became clear that we were developing some criteria for what would go in the asset map and what wouldn't. So we wanted it to be culturally appropriate, freely available. No, these are not. We haven't. These are not in cement. These are things that came up during discussion. So I don't want anyone to think that this is what we use to put assets onto the website. But this is the result of the discussion. Because, for example, a resource that could be on the website and is, I think, I've noticed there are a lot of businesses on there. So obviously that's not freely available. But so that there does need to be some clarification with some of these. But these are sort of basic guidelines to help us think about, what is it about an asset that would make it useful for the worry-free community. It has the potential to improve access to care, both for immigrant and Muslim Americans. And for those of you who are familiar with upstream and downstream models, the idea is that I love this because it's like a river. What Fatima and Margaret were saying at the beginning is sort of like that's where it started. The source is the community-based participatory research. We're now in a midstream where we're trying to work through all of these. We're trying to find out, asset mapping for now, and then in order to address the systemic inequities, which we see as an upstream goal. We are, of course, a bit like salmon then doing that, and then which is hard. And the resource intentionally engages underrepresented groups as stakeholders. And I think this is another thing, is that anyone who engages with PCORI, there's going to be a whole set of terminology in terms of describing populations which you might feel uncomfortable with. I noticed Fatima used hard to reach. And I prefer that, I think. Underrepresented, how do you define that? So, we were trying to use PCORI language to help us sort of match the asset, help us work within that those paradigms, those parameters. Very important, this one. It's available in English and another language spoken by the immigrant community, particularly Arabic. And Fatima and Worry Free have done an amazing job of translating many of the services that they advertise, information about the services that they have, into Arabic. Wherever possible, it should be available in the community area. That is important, but I have learned from everybody that community in a mosque context is complicated because, or from a worshipper's point of view, because people do actually attend different mosques. I hadn't realised that there was quite so much mobility with that. So how do you define a community area? But one of the exciting things about faith-based, as I was saying before, and which we have found with the Baptist communities, is they cross lines. They cross lines that don't normally get crossed. So they cross zip codes, they cross faith-based communities can be the whole city, or they can be everything within a whole city, or they could be just the mosques in DuPage, or they could be everything in Illinois. So they have the ability to break down the barriers of the data, the current data distribution clusters. Patient-centered, there should be respect for intersectionality. I think that's basically what the message is. That's what PCORI brings to the table, is this respect for intersectionality. Although it could do more, it could absolutely do more. There are very few projects which specifically say they have included Arabic participation. And I know, talking from folks, Korean HANA Center, we shared some results with them, and their response was, well, this is not in Korean, and I can't really, it looks good. It was about older adults and caring for older adults. It looks good, but I don't have any idea whether or not it would work because it hasn't been, shared with my Korean community. But the key thing, I think, was trusted sources. We talked a lot about that, and that these evidence-based resources should have been developed in partnership And that goes back to what Fatima and I were just talking about. And then there's the question of who manages the assets. And as Fatima will vouch, it's a work-intensive thing. And one of the things that we did at the beginning was we spent a lot of time identifying the categories. And I think the key thing was the resource priority primary category. So I wanted to show this to everybody. So basically we had in there, we had the social determinants of health. Fatima used the social determinants of health to come up with the categories that would be useful to have culturally specific or recommended knowledge about. But it's a big job, a huge job. And I think it probably does demand multiple people at the table, because as I've said, as a researcher, I can share my links, community health workers share their links, faith nurses share theirs, doctors, mosque leaders, patients. So I think the question I wanted to leave everybody with is, what types of activity will be needed to operationalize and sustain the asset map? So maybe Fatima, in 2 years' time, we can answer that. We can come up with our answer to that question.
Absolutely. I would love to answer that, because it is such a social responsibility question. Yes. And we're all in this together. And I don't know who would, being a capitalistic, living in a capitalistic society, who should come up with these.
That's right.
That's
right. It's a question of the who. Yeah, very much a question of the who. Yes. So that's that was what I was. That's our story. Our story of engaging with asset mapping in a complicated world.
Yeah, absolutely. Thank you so much. It's always such a delight to hear from you. And whenever we have these kind of these sessions, I always get insight into multiple level, into operational level, into tactics level, and into strategic level. In fact, it goes all the way to our mission. So how do it impacts our mission? So it's a wonderful thing to partner with you, and to have to partner with Pastors for PCOR. In fact, I've enjoyed everybody's company there. Pastors for PCOR is one of the collaborators with this project. I just want to mention, and I really want to take this opportunity to thank Dr. Paris Davis, Dr. Diana Ingram, Beverly Washington, who have always, all of the group has been a part of many of our sessions in the past over the period of 1 year. And it has been really been a pleasure to be working together. And especially with Dr. Johnson. And I actually end up with a friend. Thank you. Mm-hmm. Really appreciate
I have to say, I mean, you are the biggest asset.
Oh, thank you.
Because of your knowledge. I've never met anybody who understands the American healthcare system as well as you do.
Oh, wow. Oh, my God.
I hope the community understands that. Because,
thank you.
Yes, you are my go-to person in trying to make sense of it. It's very, very complicated.
Oh, my God. And you said it, and it's recorded now. Wow.
Yeah, there you go.
Wow. What did I get myself into?
That's right. So, yes. Thank you very much. So thank you to everybody who attended, and I'm glad you enjoyed it. And I know we're getting used to this format, but I think it's a nice format, and it would be nice to hear people's voices if we could, in conversation. But I think that would be that going forward. That's something to be attained in 2 years' time, Fatima. So.
Yes, definitely. Thank you again, and I'm going to leave people with some acknowledgements.